first thing that I have to see that whether it is partial or whether it is complete. If you have to see that this expanded structure that you can appreciate, yes, everyone can appreciate the expanded cisterns, as we say. Okay, so there is a, so you more than 80% of the slide is showing such expanded structures. Yes, so there should be a diffuse enlargement of the villus. So all the villus should show a diffuse enlargement, marked hydropic change, and frequent amount of cistern formation, as we can see over here. Okay, and there is a pronounced trophoblastic hyperplasia. Now I told you that all the molar pregnancies will show abnormal trophoblastic hyperplasia, but the amount of hyperplasia over here is very high. Now you must be thinking, sir, where is the trophoblastic hyperplasia? Sir, I cannot see. So outside this cistern, if you see, I will just highlight the trophoblast over here. Now, can you see over here a group of syncytial trophoblasts? Can you appreciate the lining over here? Yes, these are all trophoblastic proliferation. Over here, if you see, the trophoblastic proliferation is completely circumferential. Yes, it is circumferential. See this amount of trophoblastic tissue. Yes, so these are all the trophoblastic. Here, if you see, only few or only some of the villus shows the edematous change. All of them doesn't show. Okay, many of them, they look like the normal. They look like the normal. Yes, they are having the normal vessels, normal vascular structures are there. Yes or no? Some of these are the normal villi. So there are two population of villus that is present over here. Okay, very important. They have their contour. If you see, they have a scalloping. Can you appreciate? They have a scalloping. Okay, so this is very important that the contours, if you see, they show certain scalloping. That is very important. Okay, and they have round trophoblastic pseudo inclusions. Now, the trophoblastic pseudo inclusions are these structures which are present within the edematous villus. Can you appreciate? These are called as the trophoblastic pseudo inclusions. Difference between the complete mole and the partial mole. Okay, so everyone pay a lot of attention. So the beta HCG levels over here is markedly elevated, as we had discussed, whereas in partial mole, the beta HCG level is mildly elevated. Ultrasonography is showing a snowstorm appearance, but over here there is a focal cyst formation and also presence of fetus can be appreciated in partial mole. In the gross examination, as I told you, these are bulky. Complete mole is bulky and all the villus are involved by the hydropic change. There is no gestational sac, there is no fetal development. Both of which might be present here. And hydropic change is involving just few villus, not all the villus. Now, if you see the villus in the microscopic examination, there's a diffuse enlargement, okay, and they have round to oval shape. Whereas over here, there's a focal involvement with syncytial trophoblastic knuckle formation, as we have seen. The trophoblastic hyperplasia is marked in this case and often circumferential, and there is an intertrophoblastic bridging that I have shown you. Whereas over here, it is quite mild. Okay, trophoblastic hyperplasia is quite mild. Also, I have discussed the cytological atypia in case of complete mole is much more marked as compared to partial mole. Okay, and the stroma, as I told you, you will not be able to see any fetal RBC. You will not be able to see any vasculature over here. Okay, in case of complete mole, and there will be marked edema with cistern formation over here in case of complete mole. Whereas in case over here, only occasional cistern formation is there. Trophoblastic pseudo inclusion is present over here in case. Okay, and very importantly, the P57 staining absent in case of complete mole, whereas it is present and it is nuclear staining in case of partial mole. And today, as I have already laid out, that today's topic of discussion is gestational trophoblastic disease. Now, it is a very, very interesting and important exam question, and a lot of questions are being asked from this part. Especially, they ask you to discuss the questions that are asked. The first important question is to classify, okay, to classify the gestational trophoblastic disease and discuss GTT in details. Okay, or you are also asked about discuss the recent advances in gestational trophoblastic disease. Okay, also gestational trophoblastic disease, it is an exam slide as well, and also very commonly you also encounter such a specimen, gross specimens of H mole is also encountered. So it is a very, very sweet, small and interesting topic that we are going to understand. Not only that, we are also going to understand what all advances are there in the latest WHO that has been given. We are also going to see that. Very importantly, your a new upcoming question is to discuss IHC, discuss IHC of gestational trophoblastic diseases. Okay, so let us begin today's topic of discussion. So first we are going to start with the WHO classification of gestational trophoblastic disease. So as you can see, the classification is quite a simple one. Okay, there is not much things over here. So the first heading is neoplasms. Then we have non-neoplastic lesions, molar pregnancies. Okay, then we have abnormal villus lesions. So among the neoplasms, we have choriocarcinoma and we have placental and epithelioid trophoblastic tumor. So placental side trophoblastic tumor and epithelioid trophoblastic tumor, also called as PSTT and ETT. Okay. Now, what is the difference between the choriocarcinoma and these two tumors is that the choriocarcinoma, the phenotype of the choriocarcinoma, it resembles the villus type of trophoblast, whereas the PSTT and the ETT, okay, they basically resemble phenotypically with the non-villus trophoblast. Okay, this is very important. That is why the grouping is such. Okay, now just remember the short forms of each, because further on we are going to see the short forms. Choriocarcinoma is CC, PSTT is placental site trophoblastic tumor. Then we have epithelioid trophoblastic tumor, that is ETT. Now, non-neoplastic lesions are exaggerated placental site and placental site nodule and plaques. Whereas in the molar pregnancy, we have complete mole, partial mole, and invasive mole. So very important that why are we interested to read about the molar pregnancies? I am sure that most of you who have attended who are in the residency right now, so you must have come across some or the other mole or molar pregnancy. Okay, it is a very commonly encountered specimen and microscopy. Okay, so complete mole, partial mole, invasive mole. Okay, so why are we reading about these moles? Because there is a risk of development of a persistent gestational trophoblastic disease, or they might also develop gestational trophoblastic tumor. So what are the gestational trophoblastic tumor? Yes, if I am saying GTT, that is called as a gestational trophoblastic tumor, that is a neoplastic, that is CC or PSTT or ETT. Okay, so molar pregnancy, that is the complete mole, partial mole, and invasive mole. Okay, there is a risk that they might become persistent. So they might give rise to a persistent gestational trophoblastic disease, or they might even give rise to neoplastic lesions like choriocarcinoma, PSTT, and ETT. Okay, so that is why we have to monitor them. Can anyone tell me how do we monitor these? Yes, how do we monitor them? How do you monitor a molar pregnancy? Yes, it is an MBBS
Beta
question.
HCG.
Very good. We do the beta HCG monitoring. Now let us move ahead. Okay. Now, very importantly, that all these gestational trophoblastic diseases that we are looking at, okay, most commonly they have very similar clinical feature. Okay, they present with non-specific vaginal bleeding, or they will present as a failed pregnancy or even as a miscarriage. Okay, all the above disorders that we are looking at, they are basically showing an abnormality of trophoblastic proliferation. So this is a very, very important basic point. Okay, now the H mole, as I told you, it needs to be recognized and followed. Why? Because it might develop into a persistent gestational disease, or it might also give rise to gestational trophoblastic tumors. Okay, so that is why we need to follow them. Now, very important, we have to understand, I have used two terms over here. One term is persistent gestational trophoblastic disease. Another term is GTT. So what is the difference between persistent gestational trophoblastic disease and gestational trophoblastic tumor? So what is the difference? So PGTD is not a tissue diagnosis. Okay, it is more of a biochemical diagnosis. It is a biochemical diagnosis. Okay, so persistent gestational trophoblastic disease, okay, it refers to molar pregnancy or invasive mole or early choriocarcinoma, Okay, these conditions, okay, which is having plateauing or rising beta HCG levels. So over here, any kind of a molar pregnancy or any kind of invasive mole or early choriocarcinoma, any of these conditions, okay, or any of the molar pregnancy that I have encountered, and if it is showing a plateauing or rising beta HCG level, okay, then without a tissue diagnosis, I am just going to use the term persistent gestational trophoblastic disease. Is it very clear to everyone that whenever the beta HCG levels keeps on rising, or it is not plateauing, or it is plateauing, it is not coming down, in that case I am using the term persistent gestational trophoblastic disease. Okay, over here there is no tissue diagnosis. No tissue diagnosis is available in case of persistent gestational trophoblastic disease. Now I will tell you why we are learning these terms. I will give you the importance of these terms. Okay, whereas GTT, when I'm using the term GTT, I have already explained, it is basically used for a definitive tissue diagnosis. Whenever something is diagnosed in histopathology, okay, tumor diagnosed in histopathology as well as a clinical diagnosis of which tumors, as we have seen, the choriocarcinoma, PSTT, and ETT, placental site trophoblastic tumor, and epithelioid trophoblastic tumors. Okay, is it clear to everyone? Now you must be thinking that why, sir, why are we reading about persistent gestational trophoblastic disease and gestational trophoblastic tumor? What is the importance? See, the importance is this. Now, any kind of a persistent trophoblastic disease. Now, persistent trophoblastic disease, I do not know what is the tissue diagnosis. Just the only thing I am knowing over here that the beta HCG levels, okay, that is actually rising or it is plateau. Okay, so in that case, I'm using the term persistent gestational trophoblastic disease. It also includes early stages of choriocarcinoma. Now, why am I, separating? Because any persistent gestational trophoblastic disease is treated with first or second line chemotherapy. So the first line drug that is used is methotrexate, and they have 100% cure rate. They are having a 100% cure rate. So very importantly, any gestational trophoblastic disease in which the beta HCG levels is rising or it is plateauing, okay, it is basically treated just on the basis of the biochemical report. Just on the basis of this report, I will start first or second line chemotherapy in these patients, and they respond excellently and they have 100% cure rate. Whereas whenever a tissue diagnosis is made, whenever a tissue diagnosis of GTT is made, okay, always remember, okay, under GTT, CC also comes, but CC along with the persistent gestational trophoblastic disease, they are basically treated with chemotherapy. Whereas the other two entities, that is the PSTT and the ETT, they are treated with primary hysterectomy plus minus adjuvant chemotherapy. So it is very important to understand, okay, whether it is a persistent gestational trophoblastic disease, that means after an invasive mole, after a H mole, after a partial mole, a complete mole, when the beta HCG level is not coming down, we are calling it as the persistent gestational trophoblastic disease. That along with early cases of choriocarcinoma, they are treated with first and second line chemotherapy only. Okay, whereas placental site trophoblastic tumor and epithelioid trophoblastic tumor, both these conditions are treated with primary hysterectomy, that is surgery is the first option, plus minus adjuvant chemotherapy. Now you must be thinking that why sir is teaching us so many things about the treatment, because you have to understand when you are making a particular diagnosis what the patient is going to undergo. So in keeping that in mind, you have to give the diagnosis that what will be the implications for the patient, and you can better counsel the patient as well. So that is very important. That is why you should know that what is done for which. Okay. Now, as I told you that invasive mole, partial and complete moles, they can become persistent in nature. Okay, so around 15% of the complete H mole and around 1 in 200 partial H mole, okay, they can develop a persistent gestational trophoblastic disease. That means they will have increased beta HCG levels along with or either plateaued, okay, or the level is plateaued or it is increasing. Okay, is it very clear the concept of persistent gestational trophoblastic disease, the concept of gestational trophoblastic tumor? Yes, everyone, is it very clear? Any doubts? Yes. Okay, now we are going to start with the molar pregnancy. But before we are going to start with the molar pregnancy, we need to understand what is the basic pathogenesis of molar pregnancy. It is characterized by excessive amount of paternal genome. What is happening that there is an extra amount or excessive amount of paternal genome, and this extra paternal genome is causing abnormality of placenta development, abnormality of fetal development, and also causing abnormal trophoblastic proliferation. Okay, so if we see in the molar pregnancy, we are having two important types. One is the complete herediform mole, the second one is the partial H mole. Now in the complete herediform mole, what is happening over here, that a single sperm, it is fertilizing an empty ovum. So this is the egg, and the egg is empty, doesn't contain any nucleus. So basically a sperm over here, it is entering and it is fertilizing an empty ovum without any egg. So there is no egg, no ovum, and a sperm is fertilizing. After fertilization, the sperm undergoes duplication. So there is endo-reduplication. So everything derived from the paternal side. Okay, so everything over here is derived from the paternal side. Okay, so whatever chromosomes are there, they are derived completely from the father or the paternal side, because there is no egg. A single sperm is fertilizing an empty ovum, and that particular sperm is again undergoing duplication. So there is endo-reduplication. If you look at the genotype, it is 46XX or 46XY, like that. So there is a diploid. Okay, so there is a diploid. Most commonly, these have 46XX as the genotype. Very clear about the pathogenesis of complete mole. Coming to the partial herediform mole pathogenesis. Now, over here, what happens that the ovum is there and it is having the nucleus. Everything is present. But over here, by mistake, two sperms, okay, they are fertilizing a single ovum. So a normal ovum is present over here, and two sperms, they are fertilizing a single ovum. So there is a dispermic fertilization of a normal ovum. So that leads to a triploid conception. So there are normal amount of egg, normal amount of chromosomes are contributed by the mother. Okay, and there are two chromosomes contributing there are two sperms which are contributing the chromosomes for this particular conceptus. Okay, so there is an excessive amount of excess amount of material that is derived from the paternal genome again. So over here again, there is one extra from the paternal side. So the genotype over here is a triploid variety, and if you can see, it is 69XXY. Can be X triple X also, can be XYY also. Okay, so but the most common is 69XXY. That is the most common. So is the pathogenesis crystal clear to everyone? Any doubts? Yes. So in both the conditions, whether it be complete or partial, okay, the villain over here is the presence of the paternal genome. And if you see over here, what does the extra paternal genome do? It is causing abnormal placenta development, abnormal fetal development, and abnormal trophoblastic proliferation. Very clear to everyone? Okay, let us move ahead. First, we are going to read about the complete herediform mole. Okay, now basically, as I said, that the moles, these are non-neoplastic. Okay, so they are not neoplastic by itself. It is a non-neoplastic yet proliferative disorder of the placenta resulting in villus hydrops. Okay, hydrops. And there is a trophoblastic hyperplasia without any embryonic development. Now, as I told you, because there are two sperms in case of complete herediform mole, there are two sperms, okay, plus there is zero ovum. There is no ovum as such. So what will happen? Will there be development of any fetal parts? There will be no fetal part development because none of the chromosome came from the mother. So there is no fetal part. There is no embryonic development at all. Okay, as I told you, all of them, they have the same type of presentation. They will have non-specific vaginal bleeding in the second trimester. Very importantly, they show a marked elevation of serum HCG level. Now, why am I telling you this history? The reason is that if you do not know this history, because in the exam, the history becomes very important. Even when you practice, the history becomes very important. So this history is very, very important to understand. In which of the molar pregnancy, the HCG will rise a lot, or in which pregnancy the HCG rise will be less. So depending on that, on the clinical aspect also, we have to differentiate. You will know what is the importance I am going to tell you. Okay. Now there will be no fetal heart sound that will be heard in case of CHM. Why? Because no fetal development was there. There was no embryonic development at all. The ultrasonography, if you are going to see, they will show a characteristic snowstorm pattern in USG. Okay, so these are all the clinical findings that you will see in case of a well-developed complete herediform mole. Now, because of the excess amount of HCG, the patient might have excess amount of vomiting. So hyperemesis will be there. Okay, and other non-specific symptoms are there, which I'm not telling you. Okay, so this is very important definition. Now, I am sure most of you must have come across this mole or the molar pregnancy. Yes. How many of you have seen in the gross examination? Yes, grossing you all have done. So in the grossing, how many of you have encountered molar pregnancy? Yes. Have you all encountered?
Yes.
So it is very common. So it is not new. Okay. So what is very important over here, if you see the complete hydatidiform mole, there is a marked hydropic, that is the edematous change is there grossly. Okay. Grossly we see that there is a lot of edematous change, and it transforms all the chorionic villus into a grape-like vesicles of various size. So that we can see that there is hydropic change is present. Now what is very important over here, that well developed complete hydatidiform mole. Now look at these terms that I am saying you. They are quite bulky. Now these terms are very importantly differentiating. Okay, they are differentiating in nature. They help us to differentiate. So these are bulky, number one. Number two, all the villus that we see, all of them, they are showing hydropic change. All of them, not like partially they are showing hydropic change. No, all of them are showing hydropic change. Okay, and you cannot see normal placental structure and the fetal parts are not seen over here. So these gross findings are again very important, because later it is going to help us to differentiate from the partial mole. And this is an exam question, and in the Viva you will be asked this question. These simple questions will make a lot of difference. This is another diagram just showing the H mole. Okay, the grape like villi of the H mole that we see over here. Okay, now very very important, many of you or most of you, I hope, okay, you have seen this image. Yes, or I feel maximum of you, at least the second and the third year students, you have seen a molar pregnancy slide. Yes or no?
Yes, sir.
Yes, so most of you have seen. When I was in my residency, I used to think, okay, only the expanded structures are there, so looking at this only we will give a diagnosis of molar pregnancy. But the examiner will ask you what type, whether it is complete or partial, then how you will differentiate these. There are 10 points of differentiation given by the WHO, and I am going to discuss that in detail. Now the first thing that I have to see, that whether it is partial or whether it is complete, if you have to see that this expanded structures that you can appreciate, yes, everyone can appreciate the expanded cisterns, as we say. Okay, so there is a, so you more than 80% of the slide is showing such expanded structures. Yes, so there should be a diffuse enlargement of the villus. So all the villus should show a diffuse enlargement, marked hydropic change, and frequent amount of cistern formation, as we can see over here. Okay, and there is a pronounced trophoblastic hyperplasia. Now I told you that all the molar pregnancies will show abnormal trophoblastic hyperplasia, but the amount of hyperplasia over here is very high. Now you must be thinking, sir, where is the trophoblastic hyperplasia? Sir, I cannot see. So outside the cistern, if you see, I will just highlight the trophoblast over here. Now, can you see over here a group of syncytial trophoblasts? Can you appreciate the lining over here? Yes, these are all trophoblastic proliferation. Over here, if you see, the trophoblastic proliferation is completely circumferential. Yes, it is circumferential. See this amount of trophoblastic tissue. Yes. So these are all the trophoblastic tissue that we are seeing. Now, can you tell me the different types of trophoblast? Yes. Can anyone tell me the different types of trophoblast that is existing?
Syncytial, cyto, and syncytial.
Syncytial trophoblast, someone said. And then there was another type?
And cyto.
And cyto.
Cytotrophoblast.
Okay. There is one more type, that is the intermediate type of trophoblast. Intermediate trophoblast. Okay. Now, why it is important? This is because in the exam, all of you know from your MBBS knowledge, your examiner, he will not be interested in this. He will be interested in this. And here is where the importance comes, the intermediate type of trophoblast. Okay. So very importantly, okay, I will discuss about the intermediate trophoblast later on, but very importantly, the terms that I am laying down: diffuse, cistern formation, trophoblastic hyperplasia, and this is excessive trophoblastic hyperplasia. Very important thing, in case of complete mole, significant cytological atypia is present and mitotic figures are very common. So you have a lot of atypia to see, and this is the only type of molar pregnancy where significant amount of atypia is present. but you will not find any normal villus or any fetal structure is not present. I have explained it in grossing also. Over here also you cannot see the normal villus which is containing the blood vessels. Can you appreciate over here? No, you do not have that over here. So these are the findings. Next time you come across a molar pregnancy slide, these are the points you are going to go through. Okay. Now the villus. Okay, remember there in case of a very early variety of complete herediform mole, you might not find so much of enlargement as you see over here, but a distinct polypoid appearance is very much seen, and hydropic change grossly will be seen. Now, very importantly, I am talking about this villus stroma. Let me come to the next slide and show you. Okay. Now, first of all, look over here. Let me just show you what are these cells. Yes. What are these cells? Yes, these are trophoblast. Okay, but which type of trophoblast? Yes. Yes, these are the syncytial trophoblast. Okay. Why am I saying syncytial? They are multinucleated, but more important, look at their cytoplasm. It is completely eosinophilic. It has a complete different altogether nature. Look, and can you see these lining cells? Can you see these lining cells? Yes. Which is very much regular, monotonous looking nucleus, cuboidal, monotonous looking nucleus. These are the cytotrophoblast. These are the cytotrophoblast. So there is a lot of trophoblastic proliferation. Okay, all this is the trophoblastic proliferation that we're looking at. Now, can you appreciate this polypoid nature? Yes. Can you all appreciate the polypoid nature? Yes, that is very much visible over here. Okay. Okay. Now, one important feature over here, do you remember what is karyorrhexis? In necrosis, we had read about karyorrhex. Yes, can anyone tell me? Yes. So whenever there is a nuclear fragmentation, yes, that is called as karyorrhexis. Now, can you appreciate some dot over here? Can you appreciate some dot? Nuclear karyorrhexis is one of the very important features that we see in case of complete hydatidiform mole, and it is present in the stroma. So we call it as a stromal karyorrhexis. Okay, and if you look at the stroma, it is basically bluish. It is cellular bluish myxoid stroma. So this is the stroma that we see. Okay, it is bluish myxoid, and there is prominent karyorrhexis, that is nuclear fragmentation. So this is what we see inside the stroma. Okay, is very clear to everyone? Yes, prominent karyorrhexis is seen. Okay. Now, sometimes, as I told you, the trophoblastic proliferation can be circumferential. Okay, as we can appreciate over here. So circumferential trophoblastic proliferation can also be seen. And sometimes, as you can appreciate over here, there is a trophoblastic hyperplasia for this villus and for this villus. And the two villus are joined by this trophoblastic proliferation. What is this called as? Yes, that is called as intervillus trophoblastic bridging. Intervillus trophoblastic bridging. This is called as, it is called as intervillus trophoblastic bridging. Okay, clear everyone? So all these points are very clear to everyone. So what is the differential diagnosis? Partial H mole, we are going to discuss the differential. How do we differentiate? Okay, hydropic abortion. Now, early non-molar gestation means some gestation, okay, which resulted in a miscarriage. But for example, that is not a molar gestation. It was non-molar because of any other cause. There was a miscarriage. I will also tell you, I will also discuss how they look like. Now, very important in the recent advances is the immunohistochemistry. Now, normally, if the maternal genome or maternal structures are present, okay, they are going to be positive with P57 as the marker. But as we know, the pathogenesis of complete herediform mole, is there any maternal contribution? There is no maternal contribution in complete herediform mole. So there is an absence of the P57 nuclear staining. Remember, absence of the P57 staining is confirmatory in nature. Very, very important. Now, what is the prevalence of persistence? Means I want to say that how many percent or what percentage of complete herediform mole will have a persistent disease? Okay, what percentage is going to have a persistent disease? So I see over here that, for example, okay, that a person whenever develops a molar pregnancy, what do I have to do? I have to monitor, and I will monitor doing the beta HCG levels. So I've already explained to you what is the meaning of persistent gestational trophoblastic disease. Okay. So if the level is raised or if the level has plateaued, then we are going to label it as the persistent gestational trophoblastic disease. Now let me see if you remember. Now, what is the treatment for persistent gestational trophoblastic disease? Yes. Yes. What is the
Method.
treatment? Very good. Single dose of chemotherapy, that is the methotrexate, is the drug of choice for this therapy. Okay, so what percentage is going to become persistent? The WHO has stated that around 15 to 29%, okay, can become persistent in nature, and some percentage of complete hereditary-form mole might also get converted into choriocarcinoma. What percentage? 2 to 3% only. Now, for example, for example, someone had a complete hereditary-form mole, and then the person had a miscarriage, and the patient is asking the doctor that in the next pregnancy, what is my risk? So the risk of a subsequent complete hereditary-form mole is 1 to 1.8% after one prior and 10 to 18% after two consecutive hereditary-form mole. So the risk of subsequent development of molar pregnancy, especially CHM, increases with subsequent pregnancy. Very, very important point. All these points are given very clearly in the WHO. All these points are exam points, and just look at these slides, just look at these points. That's it. Your topic is done. Okay, nothing extra. Okay, is it very clear? The points that I've discussed for complete hereditary-form mole, more will become clear when I will discuss the partial mole. Now, as I have explained the pathogenesis before only, so as I told you over here, okay, there is fertilization of a normal ovum, but instead of one sperm, there are two sperms which goes and fertilizes. So there is a triploid conception. Yes, I have already said, and I told you in the molar pregnancy, the villain is the paternal genome. Any extra paternal genome will cause problem. And what are the problems I told you? Abnormal placenta, abnormal fetus, abnormal trophoblastic proliferation. All this thing has been discussed. So with one extra paternal haploid partial H mole, they have a triploid karyotype. And as I told you, can be XXY 70%, triple X 27%, and XYY around 3%. Okay, this is the distribution. Now you all tell me, I just showed you and I taught you about your complete hereditary-form mole. What do you understand from this diagram? What is different? What is different? Over here, if you see, only few or only some of the villus shows the edematous change. All of them doesn't show. Okay, many of them, they look like the normal. They look like the normal. Yes, they are having the normal vessels, normal vascular structures are there. Yes or no? Some of these are the normal villi. So there are two population of villus that is present over here. Okay, very important. They have their contour. If you see, they have a scalloping. Can you appreciate? They have a scalloping. Okay, so this is very important that the contours, if you see, they show certain scalloping. That is very important. Okay, and they have round trophoblastic pseudo inclusions. Now the trophoblastic pseudo inclusions are these structures which are present within the edematous villus. Can you appreciate? These are called as the trophoblastic pseudo inclusions. Okay, they are present inside. These are called as trophoblastic pseudo inclusions. So the first important point of difference from the complete mole, if you see, is that over here, in case of complete mole, there was a single diffuse edematous population. Over here, there are two populations. One, it is abnormal. One, it is looking like or resembling the normal fetal parts. Okay. Now, this is the next image, which is basically highlighting what are these? These are the trophoblastic inclusion. These are the pseudo trophoblastic inclusions. Yes, very important. Can you see the scalloping? Yes, appreciate the scalloping. Yes, everyone. Scalloping is very clear. Presence of pseudo inclusion is very clear. Okay. Now, very important over here. Okay, if you see the trophoblastic hyperplasia is very mild, and if you compare with that of complete mole, they had an excessive amount of trophoblastic proliferation. And over here, very importantly, the syncytial trophoblasts, they are proliferating in the form of knuckles. Okay, they are proliferating in the form of knuckles or sprouts. Can you see? The syncytial trophoblasts, they are proliferating in the form of knuckles. So these are the very important points. So whatever we have discussed, I'm just going to tell you that over here, in case of partial hereditary form mole, if you see, you have two group of population. One of the villus is of the normal size, okay, whereas the other one is having, edematous size, okay, expanded villus with mild trophoblastic hyperplasia, not marked. The trophoblastic hyperplasia is mild. As I told you, for all forms of the gestational diseases, the patient is presenting with non-specific vaginal bleeding or miscarriage or incomplete abortion. Okay, it is very non-specific finding. A very important point of difference from complete mole, that the HCG level, it is more of a normal, or it is just mildly elevated, not markedly elevated, as is we seen in complete hereditary form mole. And in the ultrasonography over there was a snowstorm appearance, but over here we see a focally cystic placenta. So grossly, in case of complete mole, you will see diffuse presence of hydropic vesicles. But over here, grossly, you will find both normal sized villus along with hydropic villus. And very importantly, we discussed in complete mole that no gestational sac, no fetal parts are present in case of complete mole. But over here, we might appreciate a gestational sac or fetal parts might be seen, or even an intact fetus might be seen in case of a partial mole. Okay. So partial mole, as we saw the microscopy, there is a two intermixed villus population consisting, one is your normal sized villus, as I showed you, one is your enlarged hydropic villus. Okay, very important, the expanded hydropic villus that we see has a scalloped border that I showed you, and also there is a presence of trophoblastic pseudo inclusions. Now trophoblastic hyperplasia, if we had seen as compared to complete mole, over here there is very little amount of trophoblastic hyperplasia, and usually the syncytial trophoblast, they form knuckles, as I showed you. Now very importantly, the fetal blood vessels and the nucleated RBCs are often present, okay, which can be present, and this is never present in case of complete hydatidform mole. It will never be present over there. The differential diagnosis is a complete H mole, early complete H mole, hydropic abortion, gestational with chromosomal abnormalities, placental mesenchymal dysplasia, which I will discuss later, and twin gestation with complete hydatidform mole. Now, as we had discussed in case of a complete mole, over here the persistent, again the term persistent gestational trophoblastic disease, okay, mostly the invasive H mole, it occurs in approximately 0.5 to 5%, 0.5 to 5% of partial mole. Okay, so persistent disease can develop in 0.5 to 5%. So the risk is less as compared to your complete mole. Okay, and the risk of developing choriocarcinoma is around less than 0.5%. Okay, so in contrast to the complete mole, maternal age more than 40 years and prior molar pregnancy have not been reported to be risk factors in persistent GTD. So always remember, in complete mole, if you have a prior complete H mole, then you will have a subsequent excessive risk. But if you have a prior partial mole, the subsequent pregnancy, the risk will not be increased. Similarly, with increasing age, the risk of complete mole increases, but there is no such indication in case of partial mole. Okay. Now we will see the invasive hydatidiform mole. So over here it is very, very simple. Just that, okay, we will see that there is a persistent gestational trophoblastic disease. And very important, the term invasive is just seeing whether it be a complete or a partial mole. If any of them is invading the myometrium or even the uterine vasculature, then we are using the term invasive mole. If you see over here, this is basically you can see an edematous expanded villus, and if you see, they have invaded the myometrium. They have invaded the myometrium. You can see the syncytial trophoblast over here, cytotrophoblast over here. See, some of the trophoblast is containing a lot of cytoplasm. I know you are not being able to appreciate here, but I will show you later on. Okay, they are containing excessive vacuolated cytoplasm with highly pleomorphic or varying nuclear size and shape. These are the intermediate trophoblast. I will show you later on. Okay, what are those? So over here, the molar villi has completely or invaded deeply into the uterine wall, and they are in direct contact with the myometrium. Okay, this is the invasion. This is the invasion, if you can appreciate. And this is the myometrium. Why we are saying myometrium? Because of the smooth muscle lining there. Okay, it has invaded. This is the invasive mole. Okay. Now, very important over here is that most of the invasive H mole, they are sequels of complete hydatidiform mole. As I told you, the risk of subsequent development of persistent gestational trophoblastic disease or development of choriocarcinoma or even invasive mole, it is much higher with complete hydatidiform mole. Okay, very important. Now, and both of them, as I told you, the risk is more with complete, but can develop with both partial as well as complete mole can develop in invasive mole. Now, chemotherapy is highly effective with a cure rate of over 80% depending on the extent of the disease. Okay. So now before I am going to come into the some other recent advances or the recent different forms of complete mole, I just want to discuss, okay, the differential diagnosis or the points of difference between the complete mole and the partial mole. Okay, so everyone pay a lot of attention. So the beta HCG levels over here is markedly elevated as we had discussed, whereas in partial mole the beta HCG level is mildly elevated. Ultrasonography is showing a snowstorm appearance, but over here there is a focal cyst formation and also presence of fetus can be appreciated in partial mole. In the gross examination, as I told you, these are bulky. Complete mole is bulky and all the villus are involved by the hydropic change. There is no gestational sac, there is no fetal development. Both of which might be present here. And hydropic change is involving just few villus, not all the villus. Now, if you see the villus in the microscopic examination, there's a diffuse enlargement, okay, and they have round to oval shape. Whereas over here, there's a focal involvement with syncytial trophoblastic knuckle formation, as we have seen. The trophoblastic hyperplasia is marked in this case and often circumferential, and there is an intertrophoblastic bridging that I have shown you. Whereas over here, it is quite mild. Okay, trophoblastic hyperplasia is quite mild. Also, I have discussed the cytological atypia in case of complete mole is much more marked as compared to partial mole. Okay, and the stroma, as I told you, you will not be able to see any fetal RBC. You will not be able to see any vasculature over here. Okay, in case of complete mole, and there will be marked edema with cistern formation over here in case of complete mole. Whereas in case over here, only occasional cistern formation is there. Trophoblastic pseudo inclusion is present over here in case. Okay, and very importantly, the P57 staining absent in case of complete mole, whereas it is present and it is nuclear staining in case of partial mole. Is it clear to everyone the difference between complete and partial mole? Yes. Any doubts over here till regards to complete and partial mole? So we have discussed in details the pathogenesis, the gross features, the microscopic features, and the immunohistochemical features of complete and partial mole. Now I'm going to discuss certain recent advances that goes on with it. Now, for example, there is a variety of complete hydatidiform mole called as the bifamilial variety. Okay, so over here it is a familial genetic disorder with a history of multiple molar pregnancies in families. Okay, so there is a recurrent complete H mole which is present over here. Okay, now there is a defective imprinting. Now imprinting is something that we have learned in genetics. So there is presence of one normal maternal chromosome and presence of one normal paternal chromosome. But over here, instead of the maternal chromosome, only the paternal chromosome is expressed, and that is leading to the molar pregnancy. So defective imprinting is lying at the heart of bifamilial complete hereditary-form mole. The genotype of this individual is completely normal. There is no problem whatsoever with the genotype. Again, over here, because maternal chromosomes are not expressed, you will have absent P57 immunostain. And this disorder is characterized by mutation in NLRP7 gene. Okay. Now there is a term called as mosaic complete hereditary-form mole. Over here, you have a molar pregnancy along with a non-molar pregnancy, and they are diffusely intermixed with each other. That is called as a mosaic complete hereditary-form mole. Whereas the twin complete hereditary-form mole is a condition where two separate villus population are present. Okay, so these are just few important terms that I am just letting you know. Okay, so with this we have completed in details about the molar pregnancy. Any doubts anyone is having with regards to the molar pregnancy? Acha, yes, this one is also left. Sorry. Now, one of the very important differential diagnosis of the partial hereditary-form mole is non-molar pregnancy. So sometimes we can have miscarriage because of non-molar reason. Maybe some chromosomal abnormality is something or the other is there. So how do you differentiate a non-molar pregnancy from a partial H mole? This becomes the first important differential diagnosis. Now, in case of partial mole, we had seen that some villus are of normal size, whereas some villus are expanded. Yes. So there is a variation in size of villus in case of partial mole, whereas in non-molar pregnancy, you have a more uniform villus size with regular rounded villus outlines as compared to the partial mole. The trophoblastic inclusions which was present over here, it is very few in non-molar. And very importantly, after you remove a partial mole versus if after you remove your non-molar pregnancy, the beta HCG level falls very fast in case of non-molar pregnancy after removal as compared to the partial mole. So this is also one differential diagnosis of a partial hydatidiform mole from a non-molar pregnancy. Again, partial hydatidiform mole can be also, one other differential diagnosis, as I was telling you, is placental mesenchymal dysplasia. Now, in case of PMD, over here an infant is already delivered. Okay, so infant is delivered, but along with that, what happens? The placenta that is delivered, it is abnormal with prominent placental plate vessels. But very importantly, no trophoblastic hyperplasia is seen in case of PMD. Okay, always remember the two very important differential diagnoses of PHM. First will be complete hydatidiform mole. Second will be non-molar. Third will be PMD. Okay, placental mesenchymal dysplasia. So all the differential diagnosis has also been discussed in details. Okay, any doubts anyone is having? Okay, so if you do not have any doubts, now we are going to go towards the gestational trophoblastic neoplasm or neoplasia, also called as gestational trophoblastic tumor. Okay, so yes, can anyone at least tell me what are the three conditions that we will read under GTT? Yes, what is this?
Choriocarcinoma,
What is this?
placental
Placental site trophoblastic tumor.
cytopenia,
And then we have ETT. Yes,
ETT.
epithelioid trophoblastic tumors. You have to remember